All right, our fourth and last speaker today is Dr. Don Brunnquell. He is the Director of the Office of Ethics for Children's Hospitals and Clinics of Minnesota. His work includes consultation, education, and policy regarding clinical and organizational ethics in pediatric healthcare, and his interests include end-of-life decision-making for children, definitions of children's and parents' interests and rights, and medical futility. He will be presenting a colleague's child in the hospital setting. Dr. Brunnquell.
Thanks, Doug. I want to thank Dr. Oken for continuing the dialogue that we're going to end up here about deontological and consequentialist reasoning, because you're going to hear that again. So I'm going to try to end the conference not with a whimper but with a bang, and I invite you all to express some opinions when we're done. I want to thank Doug for allegedly giving me the last word, but I'm going to thank you all by hopefully giving you time to actually have the last word as you comment on the case here. And then I wanted to thank Doug Diekema for taking some of his time to explicate the differences between a deontological and a consequentialist approach, which you're going to hear again. So, I'm going to present a case, and you've all encountered cases, I'm sure, where you have someone that you know in the hospital. And this is a particularly complex case, and I'm just going to run through it quickly. The respected and beloved Director of Social Work Services, Martha, wants to bring her child to the hospital for a disorder of sexual differentiation consultation. The daughter has been diagnosed with partial androgen insensitivity syndrome. She's now 13. She was diagnosed and treated at another hospital before Martha moved here. So that team advised her, and she followed the advice after some minor surgical procedures, to not proceed with a definitive surgical procedure at the time, and to raise Alexis as a girl. So Alexis now agrees with her mom that she wants to come to the hospital for a DSD team consultation, and they're asking for a definitive surgery towards female anatomic structure. Alexis is 13. You'll see this is an issue. But she's known to lots of people on the staff because her mom has worked at the hospital for a while. Just a little bit about her: she's been very involved in competitive athletics, very successful, and this is a big part of her identity. So Martha believes that the team at the local hospital is the best team in the region. They would need to fly for all the ongoing treatment and follow-up to a distant state. However, she's also very concerned that the consultation will become known throughout the hospital, and therefore in the neighborhood and perhaps at school. Actually, quite a number of people that she knows at the hospital live in the neighborhood. Their kids go to the school. And you're all familiar with how often people enter medical records. And just a brief survey. I thought I should actually do a study of this. I never got around to doing it. But on an average, non-complicated case, we have 20 to 40 people entering the record on any particular day, because we have so many different providers and shifts and things like that. In a more complex case, that can be 40, 60 people, and this would certainly qualify as a complex case. So there's some other complexities here. Martha is the supervisor of the social worker on the DSD team. She's also had some run-ins with the senior surgeon on this team. It's unusual for people to have those kind of run-ins, but let's just say it happened. So some of the potential providers are neighbors, as I mentioned. There's also a divorce issue here. The father, there's been a lot of bitterness about it, but the father has said, if this is what Alexis wants, I will go along with it. And Martha's also concerned about her supervisor, who she knows to be very personally conservative, and she's afraid that if her supervisor, the vice president that she reports to, finds out about this, that there could be implications for her. So she has in attempting to deal with this, she's come to the chair of the ethics committee, who she trusts, and made the following requests: that medical information about consultation be kept in hard copy only, not part of the EMR, so violating the current practice; that the assessments be done by people outside of the standard DSD team; that they use the alias situation that they have set up in the hospital. That's probably non-controversial, but that other people, that there be a minimum of other people involved, like no other members of the ethics committee, because again, the confidentiality concerns, and that the senior surgeon, who Martha believes will be angry with her and may take this out on her daughter Alexis, be asked to not be involved by the chief medical officer, who is the only person with enough status in the organization to control him. Martha has a letter from Alexis's pediatrician who says that Alexis has discussed this in depth with her, said that she wants to have the surgery and hormone treatments, she wants to have a female anatomy and continue with being a girl, continue with her friends, and continue with her activities, and her pediatrician has stated his unequivocal support for this decision. So there's some substantive case issues here. Can a 13-year-old know their long-term gender identity and the appropriateness of definitive surgery at age 13? Generally, the DSD team has said we prefer to wait until someone is 18. She's quite a bit away from that. It might be different if she were 16. But in any event, I want to set those substantive issues aside, because the first things that need to be addressed here are the process issues that are raised by this person being a member of the staff in the institution where this would happen. So the request for the I won't read them to you, you can look at them quickly, but all of these things become important issues. If we did a principle-based analysis, we would really focus mostly on Alexis's interests, and I'm not going to go through a long principle-based analysis. It's a very useful thing to do and very useful for the substantive issues, but the process issues need some other analysis. Now, the four-box model that many of you, I'm sure, are familiar with here comes the closest of our standard models to talking about some of these outside implications, but I'm going to contend that a consequentialist and feminist approach needs to be taken. And the first thing that's going to need to happen is to use that analysis and negotiate whether or not to even proceed with further involvement. So a consequentialist model would not ask so much about the presumptive duties, but try to ask what the implications are of moving away from the standard procedure in medical records, which might compromise confidentiality, the travel, the consequences of overriding the presumption of age for definitive surgery. A feminist ethics approach with two aspects, one of them being the ethics of caring, would argue that Martha has been the primary caregiver, is best positioned to know Alexis and what she wants, and but there also would need to be an analysis of that relationship. It's something that our principle-based model often doesn't call for. What is the influence by Martha on Alexis? Are we really serving Martha's needs for Alexis to be a star athlete and exercising oversight? But the feminist ethics has also highlighted issues of privilege and the assumption that many of us would have in the medical system. Well, we need to know this, we're on the inside, we need to know. And the hierarchy here is also extremely important. So concerns over the supervisory relationships and the involvement of the senior surgeon, again, all of those things will need to be addressed and assessed in advance of a decision to actually accept this case. So who can do that? The chair of the ethics committee might, in fact, be well positioned, because it needs to be someone who has knowledge of the system and hierarchical status in the system to enter into these various places, such as the medical record system and working with the senior surgeon, and someone who has trust with Martha. I just wanted to mention HIPAA concerns. This is the quote there from the "You Can Ask Your Provider." This is a quote from the OCR Consumer Guide. So it doesn't say that an organization has to agree to this, but they do offer an example where you might tell some but not other people in the clinic. So, careful consideration of who the designee is. An ethics consultant or chair of the ethics committee is a good person to do that, perhaps, and an ongoing step-by-step discussion with them about the next steps is essential. We do live in a glass house, and we have to be aware of all of these external issues that add to the substantive issues. So I'm going to stop there and ask for thoughts, responses, yuck, questions, whatever.
Go ahead.
Hi, Tor Hansen from Oslo, Norway. I'm asking in light of the legal status of a 13-year-old as far as autonomy. In Norway, the law of patients' rights states that between 12 and 16, a child has an increasing say. Now, this is a very major league issue, and we have learned that our previous understanding of how gender identity formed were rather misguided. So what are the strong reasons in this particular case from deviating from a policy which appears rather sound to wait until rather more advanced maturity has been achieved before you embark on a course of action as suggested?
And so just from the legal status, in the United States, age 18 is the line. Some states recognize decision-making before that. People in some states can be emancipated. In Minnesota, for example, there is no status of emancipated minor. But none of those things are really in question here. Nobody's made a request for emancipation. The request is for a definitive surgery because of Martha and Alexis's judgment that would best serve her needs moving forward. I agree that I don't know that it's necessary to wait till 18, but 13 seems quite young to do that. And these process issues that I'm talking about are important here because the people who would best be able to assess this, the social worker and the psychologist from the DSD team, are specifically asked to not be involved in this case. And I think that is highly problematic, whether there can be a negotiated stance of outside involvement, outside assessment with review by the regular team. That might be a compromise that would be acceptable.
Ben.
That was a great case. I was trying to sort out where you're trying to take this, because I think you accurately stated the particular challenge is the combination of her age and the request for all this non-standard stuff that makes it worrisome.
Right.
I think that from my perspective, the age would be a lot less worrisome if there was a standard approach. And so I wasn't clear if so what I find myself thinking is that the reason not to go forward is not because of the age, but because of the non-standard approach, and saying, look, particularly at this age, to go forward, we have to make sure we provide her the usual standard of care, just as Norm Foss described yesterday, the worry that we do things differently for colleagues, and saying that this is the standard of how we operate here. We have to assume people will act appropriately for medical care, or we can defer this.
Right. So that raises the issue. Martha has made a number of requests here, and it might be that what we want to do is meet some of them, like the medical record differences, maybe the request that the particular surgeon not be involved if there's other qualified people, but not meet other of her requests because of the issues, as you said, that combination of age and the knowledge of the people directly involved. So I think in terms of a practical resolution, what I want to do is try to take all of the considerations from the various sets of analyses into account and come up with something that balances some of those practical considerations raised in the consequentialist and feminist models with the more principle-based considerations.
Just following up on Ben's question, it seems to me there's also a responsibility to at least make sure that Martha and the child, Martha is the social worker.
Martha's the parent, yes.
That they are at least aware of the possibility that all of these measures are not going to be successful. Again, I'm the sort of the cynic in the audience here, and that so a lot of the repercussions that they want to avoid might in fact happen, and so that they're going into this with a realistic view about what some of the consequences might be, and if they're not willing to accept that, then maybe they ought to rethink it. And then let me just make a very facetious comment, and that in response to, I have to ask Doug, is this youth boxing open to only males? Because if it is, then my suggestion is do everything Martha wants, and then we can prevent one other person from participating in youth boxing.
Yeah, your point about the necessity of really exploring in depth whether it's at all realistic to meet the requests that they have is absolutely essential here, and not simply to say, well, we'll just trust people to act as they should with the medical record. I think in this particular case, in the glass house, that is not an adequate response, but we do need to talk about the fact that no matter what we do, it may be a problem.
All right, you have the last word. Thank you very much, Dr. Brunnquell.
Okay, thank you all.